Thanks for joining in today. This presentation is titled Prolonged Cephalosporin Therapy and Hematologic Adverse Events. My name is Bailey Francis, and I'm a PGY1 pharmacy resident at Novant Health Forsyth Medical Center. Neither myself nor any of the research team have any disclosures. Novant Health is a healthcare system that spans across Virginia, North Carolina, and South Carolina. The 3 medical centers on this slide were included in this review. Cephalosporins are a penicillinase-resistant group of beta-lactam antibiotics. They are widely utilized due to their broad spectrum of activity and tolerability in most patients. Some adverse effects include gastrointestinal side effects, rash, injection site reactions, and hematologic changes. These adverse events have been documented with multiple cephalosporins across the generations. However, time course of delayed events are less frequently documented in available literature. Hematologic adverse events may be associated with prolonged cephalosporin courses, particularly in deep-seated infections with Staph aureus. The incidence of these infections have been increasing in incidence due to the opioid epidemic, and a perceived increased incidence of hematologic adverse events has been noted recently at Novant Health. This did lead to the design of this current retrospective review. Just for background, our institution-specific dosing protocols for each of the 3 agents are listed on the slide. Additionally, weekly monitoring with CBC with differential is typically recommended during treatment with cephalosporins. We will be evaluating the current practice at our institutions and evaluating for need for more frequent monitoring. The purpose of this study was to describe the incidence and time course of cephalosporin-associated hematologic adverse events. The primary objective is to identify and compare the incidence and time course of any hematologic event that occurred during treatment with cefazolin, ceftriaxone, or ceftaroline. Secondary objectives included to identify and compare the incidence and time course of thrombocytopenia, leukopenia, neutropenia, and agranulocytosis that occurred during treatment, and also to identify adverse events requiring drug discontinuation. This study was a multi-center IRB-approved retrospective chart review that studied all admitted patients at the selected Novant Health sites from January 1st, 2016 to January 1st, 2019. The patients had to have a diagnosis listed below and also be treated with one of the study agents for a minimum of 7 days. Patients were excluded if they were missing any of the following laboratory values throughout their treatment course. If hematologic adverse effects were identified, the platelet count, white blood cell count, and ANC were collected at initiation of therapy weekly as available and at the time of discharge or cephalosporin discontinuation. Our definitions are listed on the slide as well. And Fisher exact test or Kruskal-Wallis test were utilized for statistical analysis as appropriate. In terms of baseline characteristics, the average age for the patient ranged from 45 to 57, and also the median length of stay and median duration of therapy for all 3 groups are outlined for your review. For the primary objective of incidence and time course, the incidence of any hematologic adverse event was statistically different between the 3 groups, and post-hoc comparisons showed a significant difference between the ceftriaxone and ceftaroline groups with a p-value of less than 0.001. And for your reference, the charts under the incidence categories show either the number of patients with event or the type of event broken down by drug and the duration of that treatment course. Finally, for the median time to any hematologic event, there was no significant difference between the 3 groups. However, you can see a noted earlier time to hematologic adverse event in the ceftaroline group compared to cefazolin or ceftriaxone. The difference, however, just did not reach statistical significance. For incidence of hematologic adverse events broken down into the predefined categories, there was a significant difference in thrombocytopenia rates between the 3 groups, and post-hoc comparisons showed a difference in thrombocytopenia between ceftriaxone and ceftaroline, and between cefazolin and ceftriaxone, with the p-values listed at the bottom of the slide. There were no statistically significant differences in incidence of leukopenia or neutropenia between the three groups. However, you can note a trend in increasing incidence in longer durations of therapy noted in each of the subgroups. One patient in the ceftaroline group developed agranulocytosis, which did lead to drug discontinuation. There were no patients that had therapy discontinued in the ceftriaxone group compared to 3 each in the cefazolin and ceftaroline groups. For the final secondary objective of median time to hematologic event, broken down by subgroup, there were no significant difference between any of the 3 agents in thrombocytopenia, leukopenia, or neutropenia with time to event. However, there was a trend noted with thrombocytopenia occurring first in the treatment course, followed by leukopenia and then neutropenia with each of the 3 agents. Also, ceftaroline appeared to occur earlier in the treatment course with all events compared to cefazolin or ceftriaxone. However, this difference did not reach statistical significance. It could be noted, however, that in terms of clinical significance, comparing particularly the incidence or time course of neutropenia with ceftaroline at 16 days versus cefazolin and ceftriaxone at 28.5 and 32 days respectively, this could be clinically significant in terms of monitoring parameters and recommending continued CBC with differential to monitor for delayed effects. Hematologic events occurred more frequently and earlier in the treatment course with ceftaroline. However, only the incidence of any hematologic event or the incidence of thrombocytopenia were statistically significant. This study did have minimal exclusion criteria and looked at multiple indications. However, it was retrospective with a small event size, and the varying durations of therapy could not be controlled due to the retrospective design. The timing and severity of hematologic events varied in this population, and severe events leading to drug discontinuation were only identified with ceftaroline and cefazolin. There may be opportunities to standardize our long-term monitoring, and due to the potential delayed events, weekly at minimum CBC with differential should be continued throughout the duration, and if a decline in counts are observed, consider increasing to every 72 hours. When are cephalosporin-induced hematologic adverse events most likely to occur? Within 10 to 25 days of therapy.